Welcome, folks. We'll give everyone another minute to jump on. Welcome again. Just giving folks another 30 seconds or so to jump on. Welcome, folks. We'll give people about 20 more seconds, which I know is not what I said last, but. Okay, we'll go ahead and get started. My name, for those who don't know me, is Kathy Kilring W. I use she, her pronouns. I'm the Advocacy and Programs Director at Maine Equal Justice, and I also chair the Maine Care Advisory Committee. Welcome, everyone. We usually start with introductions, and we do that with names, your affiliation or what brings you here today, and pronouns. And then we start with MAC members and alternates. Then we go to the Office of Maine Care Services, and then we come back to catch any MAC members and alternates, and then do guests. So again, names, your affiliation or what brings you here today, and pronouns. And I'll go through the MAC list to get us started. Miriam Bashir.
Hello, my name is Miriam. I use she, her pronouns. I'm a public health student at USM, and I'm also a member of the advisory committee.
Thanks. Ines El Harbi. Norma Desjardins. Catherine Brandt. Jessica Drenning.
Good morning, I'm Jessica Drenning. I work for the Office for Family Independence. I use she, her pronouns.
Jamie Bork. Or Eric Fromberg. Nilsa Ayanli. Mallory Shaughnessy.
Hi, this is Mallory Shaughnessy. Sorry I have no video, I'm driving. I am the Executive Director of the Alliance for Addiction and Mental Health Services and Vice Chair of the MAC, Chair of the Provider Subcommittee. Thanks.
Thanks. Kathy Dion.
Hi, good morning. I'm Kathy Dion, the Executive Director for the Autism Society of Maine, and I use she, her.
Becca Matisovich. Or Kaylee Hess. Vicky McCarty, Rachel Collmore, or Helen Roy, Sarah Squires,
Good morning, Sarah Squires, she, her pronouns. I'm Public Policy Director and Intake Supervisor at Disability Rights Maine.
and I know the folks from Equality Maine can't be here today. Susan White,
Good morning, Susan White. I'm here with the Maine Home Care and Hospice Alliance, she, her pronouns.
Catherine Hamilton, Leah Delicata,
Good morning. I'm Leo Delicata. I'm a lawyer with legal services for Maine elders, and I use he, him pronouns.
Sarah Lewis,
Sarah Lewis, she, her pronouns with Maine Access Immigrant Network.
Laura Cordes,
Hi, good morning, everyone. Laura Cordes. I use she, her pronouns, and I'm the Executive Director of the Maine Association for Community Service Providers, MAXPE.
thank you. And Heidi, I just saw your message in the chat. I thought no one from Equality Maine could come. Do you want to introduce yourself?
Good morning, everyone. Heidi Lester, they, she, alternate for Gia Drew at Equality Maine.
Thank you. Rachel Dyer, or Nancy Cronin, David Winslow,
Good morning, David Winslow with Maine Hospital Association.
Ann Sedlak, Bobby Martin, or Hannah Hudson, Candy Henderly, Teresa Cochran, or Kristen Goddard. Kaylee Hess, I see you're on now. Do you want to introduce yourself?
Yeah, apologies. I'm Kaylee Hess, she, her pronouns with the Children's Oral Health Network of Maine, and I'm standing in for Becca Matasovich as her alternate today. I don't think Becca's on here. Yeah. Good to see you.
Thank you so much. And we'll jump over to the Office of Maine Care Services and we'll come back in case we missed any other MAC members or alternates. And Kaylee, I saw you, so I'm going to pass it to you first. I mean, Kayla, sorry.
Oh, hi. Yeah, I was just about to say, I think you mean me. Hi, everyone. Kayla Sargent. I'm the Director of Strategic Planning and Communications at the Office of Maine Care Services, and I use she, her pronouns. I will go ahead and pass it to Sarah Fisher.
Good morning, everyone. Sarah Fisher. I am the Maine Care Outreach Specialist for the Office of Maine Care Services. I use she, her pronouns. I'll pass it to Sana.
Good morning, everybody. My name is Sana Osman, Member Engagement Manager at the Office of Maine Care Services, and I'll pass it to Jim.
Jim, you're muted.
Thank you, Sarah. Good morning, everyone. My name is Jim Citrick. I'm the Member Engagement Coordinator at OMS. He and him. I don't know who would be next.
I saw Kristen Merrill.
Yeah, I'll jump in. Thanks, Kayla. Hi, everyone. I'm Kristen Merrill. I am the State Plan and Policy Development Manager for the Office of Maine Care Services and currently serving as the Acting Policy Director. I use she, her pronouns, and I will pass it to Mandy Lee.
Good morning. Amanda Lee, Rate Setting Coordinator and for Maine Care, and I use she, her pronouns. And I will pass it to Lisa Weaver.
Morning, everyone. Lisa Weaver with the Office of Maine Care Services, and I use she, her pronouns, and I'll pass it to Rebecca Parsons.
Hi, everyone. I'm Becky Parsons. I'm the new EPST coordinator for the Office of Maine Care Services. And I'm not sure who else is Maine Care on here.
That may be everybody at the moment. Ian had to step out and he'll be rejoining. Ian Yaffe from OFI.
Thanks, Lisa. Let's jump back to MAC members and alternates. If you're a MAC member or alternate and missed introductions, you can take yourself off mute or introduce yourself in the chat.
Hi, Bobby Martin, Maine Primary Care Association. Apologies for being a few minutes late.
Hi, I'm Melissa Bliss. I am an assistive technology specialist with Maine Site, the state's assistive technology program. And I am the new representative from there because Jesse Wright asked me to take over.
Thank you. Any guests who'd like to introduce themselves, you can do it in the chat, and many of you have, thank you, but you can also take yourself off mute if you'd like to. Okay. Well, thank you all. And we'll go ahead and jump in. And my apologies again. I not only sent the MAC materials not to the MAC list, but not even to a MAC member because I just sent it to someone whose name started with MAC. So I apologize for that. But most of our items today are standing agenda items, so they should seem familiar to most folks. But please feel free to ask questions along the way if needed. And we're going to do one quick change to the agenda due to timing of when Michelle Prober, who's the director of the Office of Maine Care Services, can join us and start with the unwinding continuous enrollment update first. If that's okay, though I know Ian had to step off for a minute. So Jessica, you tell me if this is not good timing.
I would like to wait for Ian if that's okay. Yes, better.
Yeah. Oh, I see Ian now.
I just got back. I heard my name, but I did not hear the question. Sorry.
That's okay. We were just saying that Michelle is also a little late in being able to join us today. So we were wondering if we could do the OFI updates first around the unwinding.
Sure.
Great.
Yeah, sorry for having to step out for a minute. I'm trying to think in terms of unwinding, we covered a lot of ground last month in terms of where Maine's unwinding plan has shifted to. Our dashboard, just the timing of the meeting, the dashboard for February isn't updated yet, but it will be this week. I'm happy to sort of share rough summaries of where those numbers are, but at this point, we're sort of not seeing any significant shifts in unwinding from a month-to-month basis. I mean, we're just closing through the remaining people who have renewals scheduled, but we're not seeing like a significant change in, the overall number of people who are being disenrolled as a percentage or things like that. So when the dashboard gets posted for February, you'll see, a continued increase in the number of people who've been successfully renewed, a continued increase, though slightly, in the number of people who have been disenrolled, and a continued increase in the number of people who are pending the future individual ex parte process. But as percentages, those are sort of becoming pretty fixed now. Like, it's roughly 7%, for example, of people who've been disenrolled, and I could come up with the other percentages quickly, but anyway, that's the highlight. I think for us is that as we approach the end of the initial unwinding period, we've seen pretty steady outcomes and not a ton of variation. That doesn't mean the fall unwinding period, the August to October period, that's not a period that will be, that will be more unpredictable. But I think that's, increasingly our focus when it comes to outreach and communication and things like that. that's increasingly our focus of making sure that that's the period of time where we really want to pay attention and make sure that people are getting the message. I saw a question in the chat from Kathy. Can you speak to when the group that's pending gets assessed in July, what to expect in terms of disenrollments? And so roughly speaking, you know, the folks who are pending right now, once the sort of dust settles in May here, you know, we'll go through regular renewal processes again in June and July for those renewals that are due those months. And then for the renewals that go out in July, and then are due in August, that's when we'll start rescheduling people into August through October. Don't have an exact split of who's getting rescheduled when or how that logic's going to work out, but you know, there will be people that get rescheduled from August, you know, for renewals that will be due in August to October. And so those folks can expect the same, you know, processes that have been in place right now in terms of getting a notice 2 months before that renewal is going to be due, and then having the regular renewal process. The big difference there is that, you know, we'll be doing individual ex parte, so we'll have more people who are automatically renewed for coverage, even if they don't do anything. That number will increase in those months, but for people that don't respond at all, they will be procedurally closed at the end of the month that they're scheduled for. So yeah, I think the bottom line is we will see more disenrollments between August and October. The exact amounts, hard to say. The same rules around reopening will apply. So people who close and then subsequently get back to us within 90 days will have uninterrupted coverage. But definitely for the people that have, you know, not responded at all during the current unwinding period, if that happened, you know, when they're rescheduled, if they don't get individually renewed under the new ex parte process, you know, those will lead to closures or disenrollments in that time period. And I think we already shared this with this group, but the special enrollment period for Cover Me is already extended to December to account for that. So, and we'll still be, you know, for people that let us know, we'll still be referring them to Cover Me coverage as well. So hopefully that answers some questions. I didn't have, you know, any big charts to share, just because the information is pretty static at this point from a percentage basis. We just continue to work through those cases. The other thing that I just wanted to share with this group that's sort of connected to unwinding, which has, you know, increased the number of things that OFI has to do each month, which leads to longer wait times and things like that, is that we, you know, we've done a lot of work in the fall to improve telephony, to, you know, bring on additional temporary staff to support the unwinding effort. And we're seeing a return on investment there now in terms of processing, where, you know, if people are applying for main care now, they should be hearing from us faster now than maybe in the fall, for example. Certainly this time last year, faster. And we have, you know, cleared enough of our backlogs of applications and recertifications to be able to shift a small number of staff into the eligibility phone line. So while that's not going to mean that line is without challenges, we should see some marginal improvement this month across both overall number of days that it takes for people to hear back from us, as well as if they call and have a question, how quickly we can answer that question. So I'd be curious next month to hear feedback from folks if you're seeing or hearing about those processing improvements from members that you work with.
Thanks, Ian. Are there any other questions? I have one question which you may not be able to answer, and that's okay if not, but last week at a work session on the budget in Health and Human Services, I heard Ben Mann say, I think, that overall main care enrollment is higher, not necessarily specifically due to the unwinding process. Do you know, like, do we have any sense, and if you don't have those numbers today, like, does that seem to be the case that overall enrollment is higher even when you take into account the fact that we've delayed some of the unwinding?
Yeah, let me find the slide that he was, I think, referring to. Do I have, if somebody has to make share screen, never mind, you don't.
I think, oh,
So I think this might be some of what you're asking about. And apologies for not having the right like Zoom on this. But this is from November where can you still see it?
yeah.
Okay, so you can see that in April 2023, our overall main care enrollment was somewhere around 420,000. And in November 2023, that number was 416,000. And so we've only seen a decrease in overall enrollment of 5,300 people during that time period, despite despite having 23,000 people disenroll from unwinding. So in other words, we had 23,000 people disenroll from unwinding, but at least 15,000 new members in the same time period, producing, an overall dip that isn't as significant. And I think those numbers, I'm just trying to look at, I can definitely come to the next meeting and share more about that. I think we're still in that, slight decrease of the peak of enrollment in May of 2023 for main care members. The biggest, change has been now with the 300% FPL for kids that we're, even though we're seeing decrease in overall main care members, we are, somewhere around 4,000 additional kids since October, when the FPLs were increased. So yeah, definitely a complicated picture in terms of the overall effect of unwinding. Keeping in mind that we have a large number of people who are current, who have current main care coverage that needs to be redetermined between August and October. So I think it really won't be until October that we see the full effect on unwinding when it comes to members, unlike other states that have, that didn't have the individual ex parte challenge, and by this point have seen, their members, their members have decreased more than Maine.
That's really helpful. Thank you.
Yeah.
Sanaa?
And happy to come back next month with more like, what does that look like? Those are pretty easy numbers for us to be able to bring up, keeping in mind that all of our numbers are sort of eligibility system generated. So the number of people who have main care in December is different. When you ask that question on January 5th, it's a different answer than January 20th or February, just because of reopening, retroactive coverage, and other things like that can shift our numbers in the past.
Thanks, Ian. Sanaa?
Yeah, I had a question for Ian. I mean, how far are you going when you're contacting? I'm not sure if you said that before, that you're contacting people with children who lost main care due to the increase of the guidelines. So how far are you going to when they have lost main care? I mean, I've met a family that their children lost main care, and it's been a while since they were able to, and then they're still under the new guidelines. So, and they didn't know that it increased. So are you guys contacting people, everybody individually, or how is that? think you said something like that before.
Yeah, Jess, do you happen to know the status of that project? If not, we can get it for next month.
I don't know exact dates, so I would think it'd be best to speak on it next month.
Okay. I know, I mean, I think I can say somewhat easily that some of the efforts that we had planned for December for doing outreach were disrupted due to a high volume of open enrollment applications that we had to process, as well as the impacts of the December storms. But I know that that is either still an active project or something that, like, the two possible answers is that it's either still active and we're still working through a list, or that we've finished that project. And I see Kathy's point in the chat for people that go over income for main care, remembering that transitional main care exists usually for those 12 months, but that's an automatic. That's something.
Yeah, I think they passed the year, so they went through the transitional and then they lost it. So that's
Okay.
the thing. And so they didn't know that with the guidelines change in October and they could go back and get main care for their children. That's why I was asking, like, how far back are you going to contact families like that?
Okay. Yeah, we'll
Yeah.
have that answer we'll have that answer next month. Jess, if you could write that down, that'd be helpful too.
Thanks, Ian. Thank you.
For sure.
Any other questions? Okay, thank you all. We're going to do one other agenda item out of order and do the communications update. So Kayla, I'll pass it back to you.
Thanks, Kathy. Hi, everyone. I wanted to give a progress update during this time on our member engagement strategies. You may remember back over the summer, we were spending a lot of time talking about the proposed access rule and the implications that that would have for us in terms of creating a beneficiary advisory group. And I wanted to share that Sanaa Osman has done a lot of work in developing a plan for us. And tentatively right now, the timeline is looking like spending a lot of time doing recruitment activities over the summer and then having a kickoff meeting with the beneficiary advisory group this fall. More specifically, you can look forward to hearing more from Sanaa on this plan in the coming months. We're thinking tentatively maybe May. She'll go over her full plan with you all. She's working on getting input from community-based organizations right now. So there may be some changes and she'd like to present once it's more final to get your input and feedback and buy-in. And additionally, Kathy, Sanaa, and I met on Friday with the 3 members that have joined the MAC recently, Miriam, Nilsa, and Inas. Thank you again for your time. And that meeting was great. I think it was just an initial meeting, a kickoff to try to open up more communication and get more input from our members on this group. And then also Sanaa plans to work with them to go over the plan for the beneficiary advisory group. So lots of exciting things to come, and that concludes my update. Does anyone have communications questions or topics that you'd want me to cover? All right, thank you.
Thanks, Kayla. Is Michelle here now?
Not yet. I haven't seen her join.
Okay, so let's do one more out of order, if that's okay with folks. Well, Mandy, do you feel like it's okay to do the rate system reform one if Michelle's not here yet?
I don't really have much of an update other than, yeah, I think I can probably give my update.
Okay, great. Well, let's do that then.
Okay, so I was out last week, so I wasn't able to attend the sub-MAC with Laura and that group. I did start a monthly update, but it hadn't gotten finalized yet. So I hope to get that out this week, and I'll send it to you, Kathy, as well as Laura, so that both groups have the update. Not anything big to report, except we are holding the 2 forums for nursing homes on Thursday and Friday. It's a 2-part forum. for draft reimbursement for just section 67. We're going to do residential care section 97C later. Other than that, I don't have anything really to report. That's about it.
Thanks so much. Any questions? Okay, I'll pass it over to you then, Laura, for the subcommittee.
Thanks, Kathy. Good morning again. So the MAC Rate System Subcommittee met as we tend to do on the last Monday of the month of February 26th. We had a good discussion. Amanda, we did miss you. We look forward to seeing you again at our next meeting at the end of March. I believe that date's the 25th at 2 p.m. Most of our discussion was about doing a plan for this year. We heard at our last meeting that the department is moving up the start of the scheduling for the 2025 I would say calendar of rate determinations. We also are thinking about how we could educate ourselves about alternative payment models, value-based purchasing goals that the department set. There was a good shared session, I think, several months back between the provider subcommittee and the rate system subcommittee, looking at value-based purchasing models on the behavioral health side. So, we're still exploring that. And I think in our next meeting, we will look and really invite anybody who'd like to do that planning with us to kind of schedule out meetings for the next year, because we certainly would be relying on the department and want to give them some additional time. And I think the other thing that we talked about that, was raised at our last meeting was the inclusion of dollars in the supplemental budget. And I think at that time, the supplemental budget had not come out, and we were looking at the appropriations for the outstanding COLAs for section 213, 28, 65, and 92, I believe. And those funds were included in the budget. That was great to see. I certainly hope that those would go through, and providers would have access to them, depending on whether it's a majority budget or not, soon after the session ends and the budget passes. So that was an update there. The department may have more news on that front, but that was good to see. And I will post our next meeting and Zoom link in the chat. Anybody is welcome to come to the meetings. And if you'd like to be added to the list or have an agenda item, please reach out and let me know. Thank you.
Thanks, Laura. Any questions? Okay, great. Thank you all. Am I right that Michelle's still not here? I'm just making sure. I was trying to look through all the screens.
Yes, she still hasn't joined.
Okay, let's then move to provider updates. And we had the standing agenda item around the provider enrollment issues and fixes for that. Molly, I think you're giving the update on that.
Yes. Hi, good morning, everyone. One second. Okay, so on Friday, we sent out what has become and will be a monthly update about provider enrollment progress. And I know Kathy sent that around to this group, so I'm not going to go through it in detail, but please take a look at it. It did give some numbers on where we are, as well as information about system and process improvements we're making. And it also gave a link to a new document that we posted on our website. A few weeks ago, we posted a full 10 or 11 page document of all the Q&A from the January provider enrollment session that we held, all those Q&A that we hadn't been able to answer during the session. So that's been up for a few weeks. And then what we posted Friday, and this is linked in that e-message, is another document, which is a list of all the suggestions for improvement that we received also at that session. They're not the document does not have what I would say responses to everything because we're still in the process of reviewing and researching them all, but we wanted to get up the list so that you could all see them. And then we also wanted to get up the responses that we do have. So thank you to everybody who submitted suggestions for improvement during that session. And we will continue to update that document, and we will continue to send out this update via e-message monthly. We're trying to target it so that it's right around either on the day of the MAC or, you know, within a few days before the MAC. So that's our monthly target for this update. I did want to share that, and again, this is sort of in there, but month over month since November, we've continued to have improvements in overall case inventory, turnaround time for completed cases, as well as how old the open cases are. So those three numbers are really the numbers that we track. And those have been improving every month. So that is all really good news. The Gainwell team has been working really hard on this in conjunction with the state team, of course. They did take, let me just check my notes. Gainwell has brought on 2 new staff recently, and they're also actively recruiting to fill a couple recent vacancies. They've also been doing a lot of overtime, but have seen some reduced uptake in people wanting to use overtime. So they're just trying to sort of figure that out from a staffing balance perspective. We continue to work on, I know this was something that people had an interest in, we continue to work on an update to automate facility licensure. This will likely be done in stages as the Division of Licensing and Certification within DHHS moves more of their license type over to a particular system that we use within the state over the next year. So that's very much a work that has to be done in partnership between OMS and the Division of Licensing and Certification. We can't do that ourselves. And then, as I mentioned, continued work on process and system improvements by Gainwell and state staff, including some changes to the enrollment system that will make it so that there's less likelihood of providers submitting a case that ends up having some missing information or errors, so that we can try to catch it all at the beginning when the providers are submitting the case. One other process change that was made now a little while ago after that session, Gainwell has done a lot of retraining of their call center staff, and Gainwell also changed the way they do their emails coming into the inbox. It used to be that people were emailing all individual Gainwell staff, whoever they've been in contact with, and now they've routed that to a central inbox, which is so they can be more efficient in responding to questions, and also better oversight to make sure that that Gainwell is in fact responding to inquiries. So that's my update for today.
Laura?
Thank you. Molly, thanks so much for the communication and the update. It's good to hear about all the progress and the numbers being reported month over month. For HCBS, or I would say Section 21 and 29 providers, we are just not seeing that level of improvement reflected in that progress. And I'm wondering if we might be kind of, those outliers. Our providers are still experiencing delays over 90 days. And I wondered if there was some type of, your suggestion for us, how to follow up, if there's somebody particular in the department to kind of dig into those particular providers. And I would say they're under Section 21 and 29. I know at one point it seemed to be, some challenges with the HCBS forms, but I wondered if you had any insight, or anybody from your team had any insight to a particular, I guess, those folks who are still experiencing that, if you've been able to identify it. I think Mark asked the question at the last meeting, hey, for those folks who are still experiencing over 90 days, have you seen that it was a particular provider? Because I think at that time, that's what we were still hearing. But any insight and any suggestions for us?
I don't have anything particular to share about those provider types right now. I can go back and see. Definitely generally speaking, the various kinds of improvements that we're making the system and process are reflective of our analysis of what is causing the biggest holdups, whether that is on the provider side or on the Gainwell side or on the state side. So we're very much trying to target wherever the pain points are in making these various improvements. But I don't have anything particular to say about 21 and 29, but I'll ask the question. So thank you for raising that. The other thing I neglected to mention, and this is very much on my own personal to-do list, so I am the bottleneck on this, which is that I have a letter drafted or an email drafted that I am planning to send out to a number of you who represent provider associations, as well as some folks not on this call, to ask all of you as provider associations to help us help providers by getting the word out on some particular existing resources and trainings and that we already have out there, just to help spread the word among your membership about what what resources and opportunities are available. So that is sitting with me, and as soon as I have a chance to send that out to all of you, I will be doing that. So you can expect to get that from me. And Laura, I'll follow up on your question about the section 21 and 29 providers.
Any other questions? Mallory, are you still in transit? Because we could jump to Michelle if you're not in a safe place to.
I am still in transit. If Michelle's here, why don't you go ahead and have her go, and then I can go after her, which is fine. I don't have that much of an update.
Yeah.
Yeah, go ahead and let her go if she's here.
Yeah, let's wait till you're not driving. Well, welcome, Michelle Probert. We, just to catch you up, we did the OFI updates and the rates and started the provider updates. But we're going to jump back to updates from Main Care.
Great. Good morning, everyone. Michelle Probert, Main Care Director. I'm homesick and managing a sick kid as well, so I'm going to be a little bit more in the background today. Excuse me, my main update was around the Change Healthcare disruption, but Anne-Marie Todorico, our pharmacy director, has joined this morning so that she can give that update, and I will be happy to chime in with any answers to questions, et cetera, but I'm just going to turn to Anne-Marie.
Thanks, Michelle, and good morning, everyone. As you may know, on February 21st, Change Healthcare, which is Main Care's pharmacy benefits administrator, experienced a cybersecurity hack, which forced them to shut down all of their systems that evening. Main Care is not the only state affected. There are 6 states in total, 6 Medicaid states in total that were impacted by this outage. To help alleviate this outage has impacted our members' ability to pick up their prescriptions. And so some of the things that Main Care has done to try to alleviate that and provide Main Care members with their prescriptions are, we have authorized pharmacies to fill up to a 30-day supply of medications for our members. And just yesterday, we released our interim payments strategy for independent and safety net pharmacies to provide them with the funds that they need to continue to operate and serve Main Care members while we are experiencing this outage. Main Care has been communicating with our members and directing them to call our Main Care member pharmacy help desk if they're experiencing any challenges. We have noticed as these different guidances have gone out that our call volume has gone down because the pharmacies are serving our members. And as soon as I get done with the update, I'll put the pharmacy help desk number in the chat so that folks have access to it. We are meeting with Change Healthcare on a daily basis and waiting for an update related to when they anticipate their system will be available for us to be able to process claims. Happy to take any questions.
Thanks, Anne-Marie. Are there questions?
Hey, Anne-Marie, David Winslow with the Maine Hospital Association. Saw your list of the interim payment pharmacies yesterday. I don't have an ask here today, but we may be asking you sometime in the near future if maybe you could expand that a little bit more to include a couple of other what I would call smaller end pharmacies. Again, I'm not asking that today, but I just want to give you a heads up that might be coming here in the coming days, depending on what happens with the change issue. So,
thanks, David. Appreciate that.
Thanks, David. I'll just add on that if for some broader awareness, it's obviously been a difficult situation overall. It's been made more difficult by the fact that at a federal level, because we are always subject to what we have federal authority for and what we don't, and that includes what we can get federal match for. And there's no official way for the federal government to recognize an emergency that's not related to being a public health emergency. So I think we would all agree that there is definitely an emergency with this cybersecurity disruption that is absolutely having a very dramatic impact on Medicaid member access to critical services. However, for example, if we were to want to make average payments, weekly payments, interim payments to all pharmacies, and I know that's not what you're asking for, David, but if we were to do that, we would not be able to receive any federal match on those payments right now. And in the situation we're in with the budget at the moment, like the state cannot afford to put all those state-only dollars out there. So that's part of the challenge that we've been dealing with. And we've been having conversations nationally to be like, oh, this might be something that, you know, maybe Congress should think about, or could there be like discretion by Secretary Becerra in this instance? Because it certainly is an emergency. But the flexibilities that came along with COVID and the public health emergency, where we could move a lot quicker than the federal government usually allows, we don't have that flexibility right now. And so it's made a challenging situation more challenging because of that. And then I'll also say that for states that are managed care states, they may have a managed care organization that is paying their pharmacy benefits administrator, right? And so they've got more flexibility where they can ask their MCO to put some payments out there in the interim that gets to providers. But again, because we're a fee-for-service state and it's just direct payments to pharmacies, that's flexibility that we also do not have in this situation. So we are definitely one of the states, I think it's fair to say, that is struggling the most under the current situation.
Is there anything that those of us that do advocacy at the federal level could help with? Like, is this something that we should be elevating for our delegation, and maybe you can't directly tell us, like?
Well, I mean, I will say that I don't think that cybersecurity issues are going to be going away on a national level anytime soon, right? And this has been a great demonstration of how disruptive this can be for member care. And so it does feel like it would be appropriate for there to be action to recognize in this, you know, evolving world that there are different kinds of emergencies that can have just as much of, if not a worse impact on you know, care that is that can be and is life-saving, right? So yeah, I think advocacy on that level is appropriate. I'm not terribly optimistic that we'd see like immediate turnaround on that, but it's important, right?
Yeah. Well, and sometimes you never know that sometimes they can act when they want to. So and I see another question in the chat. Should the state consider having more than one pharmacy vendor regionalized so all our pharmacy services are not tied to one vendor?
That's a good question too. We do have to go through, like we do for all state services, regular procurement, and I think it's a good question. There can be efficiencies and potential savings, and also one less system for providers and pharmacies to learn if we just have one vendor. So those are like the pluses. But then to the point of the question, a downside is that if you have a situation like this, we don't have a backup PBA that we can just, you know, oh, let's just temporarily switch over to that vendor. And some other states have been able to do that. So it's a good topic for us to consider as we move forward on our regular procurement cycle.
And I just want to flag for folks that Emery shared in the chat, the main care member pharmacy help desk and also some of those announcements that went out to their networks. Any other questions related to this? And it sounds like that was the only update main care wanted to share today, right? Sorry, Michelle. Mallory, are you someplace where you can take your piece now, or should we go to something else?
No, I am actually stopped. I'm still in my car, but I am stopped, and we'll do the update. So on the provider subcommittee, we did not have a meeting last week. The topic for discussion was some of the flexibilities coming off of the reporting back into the systems, but Henry Eckerson needed to be there to speak to it and was not available. So we postponed our meeting. Our next meeting is March 27th. If anybody wants to join, let me know. I can add you to the list. I won't be dropping it in the chat because I don't have access to my computer right now. But it's on the website. You can reach me and we can add you to that list. I would say, to echo some of what Laura Cordes was saying, we are still having members with the enrollment process that are seeing 90-day waits. And again, that impacts access to services and cash flow for the provider. And, you know, if there's anything that we can do to pinpoint or assist with getting some of those ones that are more backlogged, let me know. We'd be happy to help in any way we can. We appreciate the FAQs and the information that came out. I do have a question for Michelle, actually, with the pharmacy benefits. So you're saying that the state can't, you know, continue fully providing it because they can't get the federal match. But if the state were to continue it as regular, you know, as just normal operations, would they get the federal match as a back pay? And is there any way to do that so that we don't have the disruption, especially for folks that have, you know, severe mental illness that need their medications on a you know, to have limited access is a real problem.
Yeah, so if I understood your question, Mallory, like once claims are processing, we will absolutely get federal match, and we have committed to making payments on all eligible claims. So it's really more of a cash flow issue that to make the total volume of payments for pharmacy services with all state dollars on a weekly basis is something that the state can't do right now. So that's why we have put out this initial interim payment where we're focusing on what we were hearing the most was from pharmacies that really rely on main care revenue to keep their doors open, and we're going to have to shut down if they did not receive revenue. And so that's why we targeted assistance towards the smaller pharmacies and pharmacies that are more likely to be more reliant on that main care revenue. So we're continuing to assess the situation and are open to dialogue, but that seemed like the best first step to take. And I will share that we've been actively monitoring the kinds of calls that we've been getting through our pharmacy help desk. The pharmacy help desk is intended to be member focused, and we were getting a lot of concerning calls with members being told that they had to pay or else they couldn't get their medication or being turned away. The tenor of those calls has changed a lot. So we're not getting very many of those calls anymore, which is very positive. CVS, for example, made a national statement to the press that they are honoring 30-day fills. There is a, federal obligation for pharmacies to provide these services, so that is in line with that. But it's good to hear that kind of national statement. And once we did the 30-day authorizations, we've been hearing much less about members having problems accessing their medication, and then it really shifted to. And we were anticipating this and trying to work on a solution in the meantime, but then it really shifted to the pharmacies that were afraid that they weren't going to be able to continue without payment. And so addressing that this week, I'm sure there'll be something else that comes up. I will also state, and sorry if Anne-Marie may have said this and I might be a bit repetitive, but Change Healthcare has communicated that they are working on setting up an interim claims payment system for states. Like all things Medicaid, that really has to happen on a state-by-state basis because every state is different. But we will be engaging with them shortly to see what that looks like. I don't have any statement to make or expectations around timing, but it is something that they have announced nationally and that we are going to be starting to work with them on very shortly.
So the bottom line is if anybody is still encountering trouble getting their medication filled, they should reach out to the helpline, and there is some assistance so they could be directed to where they can get it.
Absolutely. Yes, the pharmacy help desk is where they should call, and that team has been, and Anne-Marie herself has been working their contacts with pharmacies. And sometimes it's a lack of knowledge about how to just technically process this when the claims are down, right? So they've done a lot of education and screen sharing with individual pharmacies just to show them how to work what they call a downtime procedure, right? So part of it is education and training and awareness. And if we're getting more pushback, then Anne-Marie's been talking to, corporate representatives, et cetera. And we've definitely seen success in just trying to help with education and training and apply pressure when needed.
Okay, thank you very much for that. And so I don't really have anything else from the provider subcommittee. If folks have agenda items that they want to add to the March agenda, please let me know at least a week before the meeting, March 27th. And just wanted to extend appreciation for all the work being done with the Gainwell situation, even though we do still have some folks that are at the end there. I may reach out to you, Molly, for some specifics around a few folks that are really seeing some problems. So thank you much.
Thank you. Molly?
Yeah, I just wanted to respond to just some of Mallory's comments about provider enrollment, and then also give some additional updates about Change Healthcare. So on the provider enrollment side, we continue to have our escalation in place if providers have their case sitting more than 60 days. So that's still there. I know obviously an average is an average, so there's going to be numbers that are higher and numbers that are lower, but we have seen some cases go through in a matter of days recently. Yes, that's fine to reach out for sure. I'd say probably maybe better to reach out to Bill Logan or to Kenneth Jameson, our provider enrollment manager. But if you reach out to me, I will send it over to them in any case. And Jillian, I saw your comment in the chat about this change since Evergreen went live. I haven't heard that, but I will add that to my list of follow-ups as well. And then on the Change Healthcare side, I also wanted to share that because folks may not know this, that we do have other services that Change Healthcare provides for us besides the pharmacy, besides being our pharmacy benefits manager. Gainwell actually subcontracts to Change Healthcare for mailroom services, as well as for a certain set of prior authorization services. So we've been working, our contract is with Gainwell, but that work had been done by Change Healthcare, and all of that had been disrupted as well. So we've sent out a few e-messages on this as well, but Gainwell has been working really hard to put forward business continuity plans, and so most of those functions are up and running. So prior authorizations are total, no backlog there. Those are all running as normal. Mailroom includes both things that we are trying to send out to providers and members, as well as documentation that members and providers are sending in to us. We have been reviewing everything. We've been prioritizing items to be worked, according to the impact on providers and members. I can say that we do still have providers out there who submit various kinds of documentation through mail or fax, where they could be submitting those electronically through the portal. So that could be prior authorization requests, it could be paper claims, it could be documentation that goes along with an enrollment case. So we have all that, we're working through it, and working through the plans to be able to process all of that, but strong encouragement that if you or providers, other providers about are still doing things by mail or fax, this is a good opportunity for them to move to electronic submission of those items through the portal. In the short term, that will there's no disruption to anything that's flowing through the portal, and so it will help some of those things continue to process, but longer term, also just sort of logistically easier, for everyone. So I don't see a high risk on any of those things that I mentioned. Like I said, Gainwell's been working really hard on standing up backup plans and workarounds and their business continuity, but just for the sake of transparency, I wanted to let you all know that. And so if you have, or other providers about have sent in things via paper, there may be a delay in processing some of those things.
Thanks, Molly. Rachel?
Yeah, thanks, Molly. So just to be clear, so the potential for mail and fax slowdowns, that's more on the provider end and less on the member end. So thinking about faxing applications and mailing in documents, is that something that we should be concerned about from a consumer facing perspective?
No, if you're talking about eligibility applications and documents related to eligibility determinations, none of that is affected by this. All of that is Office for Family Independence, not impacted at all by this Change Healthcare outage.
Great, thank you.
Mm-hmm.
Any other questions related to these issues? Okay, we'll move on then to our dental subcommittee updates, and I'm going to give those, they're pretty brief this month. I did want to share a link in the chat to one of the latest dental measures reports around the utilization of the adult benefit. It also includes some data around kids, and people are welcome to look through that. We can give a more thorough update on the latest report next month, because next week we're going to be getting a presentation from David Jorgensen about the latest dental measures report. So we'll have a little better sense of key points we want to lift up around the data at our next MAC meeting. I also wanted to lift up that there continue to be some challenges around provider enrollment or providers who take MaineCare around some red tape issues that keep coming up. They're like bureaucratic issues that are related to just processes within MaineCare. So we've this has been an ongoing thing. We've brought this up at this committee before, that we have a spreadsheet where we try to identify those issues and then share it with folks from the Office of MaineCare Services to see if any of those can be addressed simply. And then if there's other things that might require more of a policy change or something, it can be at least considered by the department as they're moving through their other policy changes processes. And we've talked about this before as well, but we are at the beginning of doing the rate redetermination for Section 25, which is the dental services section. So we'll continue to be sharing information at the subcommittee about ways to participate in that, and trying to encourage providers to participate as appropriate. I think those are our big updates. I also just wanted to name one thing that comes up a lot when we talk about dental care, and it comes up a lot in this subcommittee as well, which is that there are things that are within the scope of main care to address potentially, and there are things that are outside the scope of main care. And so our subcommittee is more focused on the things that are within the scope of main care, though we can't help but talk about things like workforce, which is a huge problem. And I know that's true for other areas of care as well. And so a lot of times when we're talking about challenges around access, one of the things that's a recurring theme is just the lack of certain types of providers, particularly specialists, which we just have a shortage of in Maine. And this is actually a problem nationwide when it comes to oral health care. But Maine has particularly high levels of shortages. And then that there's also challenges across the whole spectrum of providers. So whether we're talking about assistants, hygienists, dentists, or specialists, there are shortages. And so while there are certainly things main care can do, and we talk about this at the subcommittee a lot, to encourage provider participation in main care and enrollment so that they take patients, there will continue to be access challenges, both for main care members as well as for people with private insurance or no insurance, as long as we continue to have these shortages across the workforce. So I do just want to clarify that, because sometimes people will ask, what are we doing about the workforce challenges? And many people who are in the subcommittee are also in other spaces focused on workforce challenges, but that isn't, well, it comes up a lot. It's not really the focus of the subcommittee, because the solutions to that really don't live within main care, if that makes sense. I don't know if anybody from the subcommittee wants to add anything. Any questions? Michelle?
Hey, Kathy. I just wanted to share for awareness that there's a LD 307. I think that this afternoon they're taking testimony, and that LD would require the state to contract with a dental services administrator. I think it's fair to characterize it as managed care for dental. And so we say in our testimony that one of the, there has been some general discussion and statements that it's possible that dental managed care could help improve access. That has been shown in some other states, not all other states that have made this change. But I think the theory behind it is that there are more dentists who are used to working with some of the dental managed care organizations, and so might have efficiencies on their end and more comfort with those kind of processes, et cetera. But we state in our testimony that there has not been a lot of dialogue, and I've raised this a little bit before about whether, our providers and members and stakeholders, if that assessment is kind of shared, that this might be a helpful thing. And so we think that there should be more work in that area. I think the current bill is also making an assumption that this could be a cost savings measure. And so we are also making the statement that even if there are some savings in some areas, we don't want decreased utilization, we want increased utilization. And so if we were to go down this path, it would be in the hopes that it would help increase utilization, which comes along with cost increases, not decreases, right? So we're also just kind of trying to encourage that everyone's on the same page with their expectations and objectives for a potential change like this. So I just wanted to highlight that bill and some of the questions that come up around it, especially if some folks weren't not aware of it.
Thank you for that. And what you just said is very aligned with what I'm going to say in my neither for nor against testimony this afternoon. But I want to say that I also think we have tried, there have been times where this question, it's 307 is the LD number. But I don't think you can see the amendment by just looking up 307 online. I think you might have to have someone who got the email from the interested parties list for Health and Human Services or HCIFS before that, that has the amendment to send it to you, Franco, because I don't think they update with the amendment until the committee finalizes an amendment. But the, what was I going to say? Oh, especially right after we passed the adult dental benefit legislation in the budget in 2021, we did have some conversations at the subcommittee about managed care and whether or not that was a potential way to address some of the access challenges, but it hasn't really been a thing that's been promoted at the subcommittee level. And I haven't gone out of my way to make it a big part of the conversation, not because I'm against having the conversation, but I'm not an expert on that and have created a few opportunities for folks who maybe are more expert on that. And they haven't taken me up on it. So, but I do think it is a conversation. This keeps coming up, like managed care bills keep popping up, and they often seem to pop up at the end of sessions or at the end of a part of the session. Not just dental, but also like larger managed care bills. And so I guess one thing it might be worth us thinking together about as the MAC is like, is there a space to have a conversation about that? Where we actually have the time to look at the pros and cons and potential challenges, and particularly from my point of view of like, how do we, if we did decide that we wanted to go down that route for any of our healthcare services, how do we do it in a way, to your point, Michelle, that does not reduce access, but actually increases access and has more people utilizing those services? Because ultimately what we really want is for all the people who haven't had dental care to be able to get dental care. So I guess that would be a good thing for us to think about as we also talk about maybe some of our strategic planning conversations for the MAC after session. Because I'm not quite sure the best way to have that conversation, and don't want to imply that the conversation itself means a certain position on managed care, but also it feels like it would be great to have the conversation not in the last weeks of session, which it keeps happening. So I'm just saying that's my soapbox.
And Kathy, I will share that actually, I don't remember the LD anymore, but from last session's broader managed care bill, what came out of that bill was a request that, sorry, it might have actually been 2 sessions ago. I can't keep track. But what came out of one of the past broader managed care bills was asking the department to do a study on feasibility of dental managed care. And so we did actually work with somebody to do that report, and that is a report that I'm willing to share that with the dental subcommittee, and we're reminding the legislature of that report as well, because it just looked at what different states are doing and what outcomes there have been in different states. Again, this is just focused on dental and not managed care more broadly, but FYI. And I haven't heard yet about an LD focused on broader managed care, but if you know about one already, let me know, because I'd love to have a heads up to have that annual conversation again.
Yeah. Catherine?
Yeah, thanks for bringing up a very important topic. And I know this is going to be a parking lot thing, but as you are looking at this, or it sounds like as it has been looked at, has it been on the radars that most of the costs of not having access to dental care tend to fall in other categories, like regular medical care? So people who have out of control dental issues are going to pop up as uncontrolled diabetes or hospitalizations for infections or other sort of complications of poor oral health that don't fall under oral health.
Yeah, thank you so much for lifting that up again, Catherine. That is definitely something that was, I think, a big part of the impetus behind passing the adult dental benefit in the first place. Like many of us who were advocating for that, and I think ultimately, I don't want to speak for the department, but like there were compelling reasons why it actually would be both beneficial to oral health, but also to overall health in many other ways. Bobby?
Hey, thanks, Kathy. I wanted to just take a moment to kind of support some of the things that you just said. I was thinking about managed care and dental yesterday, and because, you know, we're all nerds and that's what we do in our free time. But the question that arose for me was, how does this fit into the bigger picture of Maine Care and the future of healthcare services in the state? And I've noticed that these recurring bills keep coming up every few legislative sessions, and there's a strong, you know, level of support, and then there's some strong resistance to it. But there are states where systems have been created, and I come from one, that have improved access, have improved health outcomes, and have been very successful. But it's a system that is designed intentionally, locally, with community partners from the very beginning, and not one that is voted on for outside entities to come in and make profit off of. And so I think it would be really important in the context that this is going to keep coming up because there are vested interests, including players out there in the market trying to get a slice of the Medicaid pie in Maine, if you will, that it's important to talk about what we want to see happen with the healthcare system and what options there are moving forward. If we were to design some sort of care management setup in Maine to address these things, who would we want to model it after? What would be the key considerations so that we're not ceding this to outside interests to drive their interests in what Maine does moving forward, but that we talk about what would a model look like that would benefit, what would we want out of it? And I think there's some good work being done nationally in some of those spaces. And it's not the ones that are promoted by bills from outside national for-profit entities. It's usually driven by professionals in the state and partners that really have a vested interest in both the community health outcomes and the organization of the system and the improvement to access that can come from it. So I think that's something that we should put a pin in and think about as the Maine Care Advisory Committee, to say there's got to be a venue for proactively talking through this rather than being reactive to what bills come from certain stakeholders in any given legislative session when no one has time to really think about the implications and understand the implications. So that's all I had to say.
Thanks, I appreciate that, Bobby. So let's do that. We are planning to come back to like talking about some of these bigger picture questions post session. So that I think it sounds like this is one where there's some energy to have some focus on.
Kathy, if I can just say one last thing, which is, and thanks, Bobby, for those comments. And this is somewhat related, but one common theme that we see in all of these bills is also some very unrealistic assumptions about timeline and scope and impact of these kinds of changes. Switching managed care, whether it's just for dental or for all of a Medicaid program, is a gargantuan task that really flips all of the operation. I mean, so I'm just going to speak right now from like a logistics, Maine Care centric as our Office of Maine Care Services perspective, but it flips everything on its head. And it's also a complicated process to go through approval for CMS. And so oftentimes it's presented as like, and I think outside interest can be a part of it, right? But like, oh, let's just come in and do this thing and we'll do it really quickly. And those timelines, one, are totally unrealistic, even if we know from the outset exactly how we're going to do anything. And two, they also do not build in any of that stakeholder engagement and like broader, bigger picture, intentional process that I would agree is really needed for success on whatever big broad scale initiative you undertake.
And I realize there's probably folks on this call who actually don't know what we mean when we keep talking about managed care. And Michelle, if you're up to it, do you want to explain what the difference is between managed care and how we pay for services now? Or if you're not up to it, I can try.
Yeah, I can do it at a really high level. So basically, right now, the Office of Maine Care Services, we essentially run a health plan, right? Like we provide health insurance and we are responsible for all of those operations. Under managed care, which is what the considerable majority of states across the country utilize for most of their Medicaid populations, you basically contract with a separate entity. Most commonly in other states, that separate entity is a large health plan that you might have heard of in the commercial space as well. And you pay that health plan an agreed upon dollar amount for every enrolled Medicaid member for each month that they're enrolled. And basically that managed care entity, that health plan, holds the risk for paying all the providers and monitoring utilization and basically running the health plan under that capitated amount. And so on the state side, it provides more predictability and like in what you're paying for healthcare for the Medicaid population on an annual basis. And the managed care entity holds that risk. And part of the reason why some of those entities are why they're interested in this space is because if they are able to meet their quality measures as well as cover the costs at a lower price than what the state pays them, then they can make money off it. So there's a lot more than I could say, but that's the general premise in a nutshell.
And I'll just add, and this is my opinion, but that I think it varies widely in each state what that looks like from a consumer perspective. Some states, I think their experience with those managed care entities is really positive. And in some states, it's definitely a barrier to getting all the care that people need. So that's one of the reasons why some of us are very cautious about making that change in Maine.
And there's also, it used to be much more black and white of like, you have these health plans or you don't. And I think partly what Bobby was talking about is that some states have done much more creative things where there's kind of there may be partnerships between direct providers of services to become that accountable entity, right? Or a hybrid of like an accountable care organization model with managed care. And so there are numerous examples of more creative approaches too. And I'll share a link in the chat if I can. There's a really excellent short digestible podcast about managed care by this podcast called Trade-Offs that I think it's just really helpful. So I'll share that.
Thanks. And Bobby, were you trying to say something?
Yeah, I was just going to say, and that I think that's my point entirely, is that what you get in managed care comes out of your plan and design moving into it. And there's ways to do it well so that it is a net community good and requires reinvestment in the delivery system and reinvestment in services and lessons learned from those, I think, are important. That being said, it's also really important to think about to learn from states that have done it wrong and where managed care has not been successful and has not improved access. And what I assume and what I've heard anecdotally is that some of the bills that are passed are by more of those outside of Maine entities that are the more familiar health plans that do see a profit margin in the model and stakeholders that want to see earnings. But there's also models like the one that I came from in Oregon where the model in itself really reinvests continuously in the community while exponentially improving clinical quality metrics and outcomes. And so the more work you put onto at the front end to really design a plan with what you want to get on the outside, the more you prevent having a system put upon you that is just another replication of a model that is less than ideal. So I think Michelle and I are saying very similar things in that there's caution. You need to really identify what are the things we don't want to see happen, what are the things we do. And that's not going to come during a legislative session where everyone's there to react to a proposal. But I also, I think it's a conversation we should have because there are potential benefits to be had and potential advancements in the way healthcare is delivered and how resources are utilized that would benefit. So I think that should be a discussion with appropriate stakeholders, not in the context of, are you for or against this bill? because I think that that's a artificial and potentially destructive way to go about such a major change, like moving into a managed care environment.
Thanks, Bobby. Mallory?
Thanks. While we're having this sort of broader conversation, I am curious. In Maine, we don't have a managed care, but we do have an ASO in Kipro or Accentra, I think they're called now. But it's only for behavioral health care services. And I'm just curious to Michelle, you know, we have this system for just one part of our main care service line. And I guess, you know, when we talk about these things, it would be good to have a conversation around that as well. The fact that there is this other entity that is part of the landscape in Maine that does do similar to a managed care, provides that utilization review and some of these other pieces that in many ways becomes that administrative sort of add-on burden for those providers that other providers don't have within the main care landscape. I just want to kind of put that out on the table and you know, make sure that we recognize that as we're having this broader conversation.
Yeah, agreed, Mallory. And I'll also just call out that our Change Healthcare as our pharmacy benefits administrator, because some states have pharmacy wrapped up in their broader managed care, and you can have a separate managed care pharmacy carve out, right? So, so the difference both with Accentra and with Change Healthcare is that they are providing administrative functions that we pay them to provide, but we're not paying them a capitated amount and saying, okay, you have to be responsible for the cost of this population within this dollar amount. It's more of like a pass-through administrative function for both of those entities.
Thanks.
Well, Mallory, you want to say something else?
No, I just think that needs to be part of the conversation. But I agree with Bobby fully that maybe this group as an advisory committee could take up this issue in the summer months and you know, outside the legislative process to look at what could be a potential way to move forward.
Okay, well, we'll come back to this. Thank you so much all for some good conversation. And some of us, I think, will probably be trying to listen to the podcast later. So a good learning opportunity too. Any questions about the dental subcommittee? Because that's where we started this. Okay. And so last up on our list is the rulemaking waiver spa packet. And I'll pass it over to you, Kristen.
Thanks, Kathy. Hi again, everyone. I really don't have much in terms of updates, rule-specific updates this month. I think I would just note that we did hold our public hearing for Section 23, which is our developmental and behavioral health clinic services. For those of you that are familiar with it, that's the rulemaking that proposes to add our foster care comprehensive health assessment. We held that public hearing on February 20th. Our comment period just closed on March 1st. So any comments that we received are currently under review as part of our Administrative Procedure Act process. So that rulemaking is moving through. In addition, we do still have our Section 20, which is our home and community-based services for adults with other related conditions, and Section 31, federally qualified health centers or FQHCs, which is both are currently in pre-review with our Attorney General's office. And we also have our Section 94, which is our EPSDT or early periodic screening, diagnosis and treatment policy, which is in its final adoption review stage, also with the Attorney General's office. Couple of big things I'd like to note, just in the last couple of weeks, we did receive CMS approval on a few of our 1915C waiver amendments. Those amendments specifically relate to Appendix K flexibilities. So as I think a number of folks are aware, under our HCBS waiver authorities, flexibilities did extend a little bit beyond the end of the public health emergency. And in order to retain some of those flexibilities, states had to submit waiver amendments to the federal government for approval. And so the waivers that we recently received approval on include Section 18. We refer to that as our ME 1082 waiver, which is home and community-based services for adults with brain injuries. We also received approval on our Section 21, which is home and community-based benefits for members with intellectual disabilities or autism spectrum disorder. We refer to that as ME 0159. And our Section 29, which is our support services for adults with intellectual disabilities or autism spectrum disorder. We refer to that as ME 0467. I think those are the big updates. I would list out all of the provisions that were included in the waiver amendments, but it's a pretty hefty list. We did issue notices, a number of notices over the last several months. I can drop one of the more recent ones, which was towards the end of the last year, into the chat if folks think that is helpful. But otherwise, I think that's the big items. Looks like maybe Mallory, you might have a question.
I do. Thank you, Kristen. So with the Section 23 review that you did, it was actually only part of Section 23 and not the full Section 23. And there's still, some major issues around the fact that the other part of 23 has not been reviewed in probably a decade. But I don't see it on the list either to be dealt with at any time in the near future. And I just wanted to know if you could speak to that at all.
Yeah, thanks, Mallory. I think to restate what I think you're referring to is specifically the addition, as I mentioned, of the foster care comprehensive health assessment under Section 23. That was a legislative directive to the department to implement that service. And so we undertook rate reform efforts. And as Mallory mentioned, other services encompassed in Section 23 were not reviewed as part of that rate reform effort, and so are also not included as changes in this rulemaking. So I can't really speak to timing for the Section 23 other services process. I will say that, I think most folks are aware, and Michelle spoke to this last month, but we do have our technical advisory panel, which we discuss annual rate reform efforts with. We, offer the public to participate in that process and comment on changes in addition to the TAP members. So that avenue does exist. We are aware that, after our last couple iterations of those meetings, it does appear as though, once we stop accepting comments on those efforts, we do hear through other avenues about sections that that providers or interested parties would prefer included, but we are kind of bound at this point in time to our timelines and our processes related to that. I don't know, Michelle, if you want to speak at all to the TAP process again in this meeting.
Thanks, Kristen. I'll just say that and this comment applies both internally as well as externally. So as we're all getting used to having a new rate reform statute, it's helpful for us to remember internally across different offices and even within each office that we all need to be actively thinking about and elevating services that are in need of broader rate determination. And then that is the case externally as well. This is one example where, I think that the work started because there had been legislation and we were overdue in acting on it. And so people started working on this specific thing within Section 23. And unfortunately, there was neither the issue of the other remaining services in Section 23 was not raised or elevated either internally or externally during our process of determining our calendar year schedule for the rate determinations. So just a public service announcement, everybody, please speak up early and often in that process so that it is less likely in the future that there are omissions that we collectively wish had not been omissions. Having said all of that, we've been having conversations with the Commissioner's Office on this front, and we are very actively assessing how we can work within constrained resources and hopefully act more quickly, even though the broader Section 23 is not officially on the agenda. So I don't have an update to share in terms of how we're going to do that or the timing, but there is a shared desire to move earlier in a rate determination for that broader set of services.
Thanks for that update as much as you can.
I have a question that's based on the budget work session last week. So as many people on this call know, I think there's a proposal in the supplemental budget to roll back an expansion of the Medicare savings program to higher eligibility levels. And that program helps older Mainers who are over income for Medicaid, but who might still struggle with healthcare costs through Medicare, to get support with those costs. And there was a significant expansion that passed in the budget last year. And I'll just know in the Health and Human Services work session on the budget, they voted to reject that rollback and to direct the department to implement the changes that were passed last year by July 1st. Originally, they were supposed to go into effect on March 1st. I'm bringing this up. I know there's still a long way till we're done with the budget, and we don't know that that's what the ultimate outcome will be. But in terms of, I believe there's a state plan amendment that has to be filed as part of that change. Am I right about that? And if so, like, how would that work? Would you wait until, if ultimately the legislature does say you have to follow the law that was passed last year, but we'll give you a little more time to implement it? What would then happen? Would you then file a state plan amendment and then we'd have to wait for rulemaking? I know a lot of rulemaking around eligibility has been delayed over the last couple of years. So I'm just trying to picture like what might happen, and maybe you can't comment on it because it's still too up in the air.
Yeah, Kathy, and I welcome Ian to chime in as well, but we are just really beginning to process what's coming out of budget actions from last week. And so this was acknowledged this morning, but there hasn't even been time for there to be discussion or how do we proceed with next steps. So I think that we need some time to be able to process that, and we can speak in more detail at a future date. But if Ian has additional information he'd like to share, he is welcome to.
Yeah, I think that's probably the right answer. I would say, once we know what's happens with the budget, I can pretty readily come up with an implementation timeline based on that. It's not a complicated changing FPLs within the Medicare savings program has lots of complicated conversations going on about them. But changing them mechanically on the side of, on our end from an eligibility perspective is not complicated. So as soon as we know what's going to happen in the budget, I should be able to get you a timeline of what we're doing to implement as soon as we know what we're supposed to implement.
Thanks. I wish I thought we might know what's going to happen with the budget by our next MAC meeting, which is April 2nd, but I'm guessing we probably won't.
I will hold it to your prediction. The budget will be resolved by April 2nd.
I wish I could say that. My guess was April 12th. But I think if it's not final or has only just become final, it's probably more likely that we'll be able to have a conversation about that for May. So I'll just flag that for them. But I know there are a lot of folks on this call that are watching that very carefully. Any other questions? Okay, so I just wanted to quickly flag the things that I think we flagged as potential upcoming conversations. We can circle back from OFI around some of those enrollment numbers and some of the dynamics there that we talked about earlier, and also can circle back to the outreach around folks who had previously lost coverage for kids who are now eligible. We're gonna circle back to strategic planning, though that might be May, not April. I think it probably makes sense for us to plan to have an update on the pharmacy challenges, so maybe those will be more resolved by April. And I put a pin in the conversation around managed care to be part of the strategic planning conversation. Is there anything else that came up that I was supposed to flag as an agenda item for next month? That's not one of our standing items. Oh, and I think we said that the updates on member engagement pieces will probably happen in May, so that's not for next month. Okay, all right. Well, if you do think of anything else, give me a heads up, and I hope you all have a wonderful day.
Thanks, all.
Bye, everyone.